And our next speaker is Dr. Monika JETHANI. She is going to speak on microkeratome. LASIK is still the best. Dr. Monika, please.
Good morning, everyone. I would like to thank Dr. Vinod Arora for including me in this wonderful instruction course. So, why are we discussing about microkeratome in 2025 at All India Conference? Let's look at some of the pointers for the same. So there are variety of microkeratomes available in the market, and the whole purpose of putting this slide is that it has reached a stage where no more developments are taking place. If you see in years after SBK and ML7, we have not come across a newer microkeratome. Reason being, it is a quite well-developed technology by now. There were different types of microkeratomes available, and now we have come to a conclusion which one is the best for us. To look at it, initially the lenticules which were made by the rotatory microkeratomes, which were available with Bausch & Lomb machine, Z100, and I have been fortunate enough to use almost all the microkeratomes and almost all the LASIK machines possible. So now the microkeratomes which are available make a quite linear and planar flaps, which was possible only with femto. And this is a comparative list between the different kind of microkeratomes available. Initially, when my father started, they were making flaps of around 140 microns. But now, with the microkeratome also, I mean, it has been years that we can make a flap of 90 micron, which is the minimal. And we have microkeratomes like ML7, where you can just change the blade and you can alter the thickness of the flap, like -10, +10, all that things are available. We all have heard this saying that old is gold, and so is true with microkeratomes. We have to understand and analyze, and I think one of the most important factors for putting this presentation into AIOS 2025 is we stay in India, and value for money is also very important. If we come on this stage, it is only 1% of ophthalmologists who are speaking about these machines, and as listeners, we take home back that if we do not have Contura, or we do not have Silk, or we do not have Smile, then we are lagging behind somewhere. I don't think that's true, and we have to understand, and as speakers, we have to preach this, that microkeratome is also going to stay. If we take home this message, this is the extremely important slide, that we should not be reusing the blades. The most of the complications and problems which arise due to microkeratomes is because of the reuse of the blade, because it's in the hand of doctors. There are people who use it for single patient, and there are people who use it for the whole session they have on that day. So that ethical practice we need to follow. So this we have already discussed, that 90 micron is possible. So in conferences, we hear people speaking about buttonholes and free and incomplete flap. But if you look at the reality check, what is the incidence? I mean, in 13, 14 years of my career of LASIK, I have never had a buttonhole. So why are we still talking about buttonholes with microkeratomes? Just because we want to promote a newer technology, we want to bring that machine into the market, we degrade what was already available. So now we have comparable flaps with femto, and the post-op wow effect, I would say, when I had used femto, it is much better with LASIK than with femto, because of, I mean, on the next post-op day, and then both of them become equal. So limitation of Smile is that still work on hyperopia is going on, and on lasers, where we think to minimize the thickness of the stroma, the thickness of the cornea, which we use for correcting the refractive error. In case of smile, when it is a very small diopters like 0.5, 0.75, we have to do a flat head. So we have to understand that smile is still a developing technology, and now something like silk has come into the market. They would change something from planar to biconvex, and they want to launch 6.5 crore machine into the market, and we as ophthalmologists are compelled. So in institutional practices, it is possible, but in general practice, we have to understand that it is not that important, and we cannot go ahead with refractive surgeries with microkeratomes. Also, even if you see in animations, they would not show the manual separation. They'll just show an incision made and lenticule comes out, which is not the reality. You have to separate the lenticule manually. You can easily see that lenticule is being separated manually in smile. Opaque bubble layer, I know now is not a problem, but still why I have included this slide is that if we position the spots, two spots very close, then there'll be opaque bubble layer. So now we cannot position the two spots very close, and that is why manual separation you have to do. It has got a little steep learning curve. And if we discuss about pros and cons of LASIK, LASIK has been a very predictable procedure, very quick recovery, high diopters can be treated. It can also correct hyperopia, and thinner flaps are possible. Cons are two-step, problems with flap may occur, and chances of free flap, folds, and stria. But after having said that, if your technique is beautiful, if you take care of the vacuum part, if you take care of repositing the flap properly, I have not come across any micro or macro stria in so many years. So coming to the conclusion, take-home message is old is gold. It's cost-effective. Reuse of blades should absolutely be avoided. Manual separation is needed in smile or silk. No buttonholes, 90 micron is possible. Nasal flap is possible, in which we can preserve maximum number of nerves, and its value for money. And to conclude, I would like to say that pre-operative workup is the key. We are talking about Contura correcting 4 microns, 7 microns, which is the thickness of the tear film. So what are we correcting? And I'm not at all against the technology. We always adapt the technology, and the show must go on. And you have to understand that you are important and not the machine. Be so knowledgeable, you master your own machine and not let the machine master you. Thank you so much.
Thank you so much. I think the microcotome has evolved a lot from what we were getting much earlier. Now we can get a planar flap just like femto. We can get a oval flap. So I think it's quite comparable and much economical, easy to learn. Of course, every procedure had some complication.
Yes,
Nothing
sir.
is, no surgery is without complication.
Yes, sir.
So every machine has its own set of complications. You can't say it's with this one or it's with this one. So we have to learn them and be prepared for them. Thank you so much,
Thank
Dr.
you, sir.
Monika.
Thank you.
And our next speaker is...
Hello, there's a small question.
Yes.
Please.
Like they say that in microkeratomes,
Yes.
there can be a tendency for a free flap.
Yes, sir.
So what key readings you take pre-op as a safeguard? You don't go less than that for free flap or even buttonholing for that matter.
Sir, honestly, I have operated at 40 also. The only thing is that you have to be very, very cautious with the ring size what you are
Yeah,
selecting.
yeah, exactly.
Usually what has been seen is only the most common ring size are used until and unless, the K readings are very steep or very flat. What we follow in our setup is we change rings even for 2 eyes of one patient. So that's very important, and the most important factor is proper achievement of vacuum.
Yeah.
If you check your vacuum, flap complications would become a history.
Yeah, exactly. And
So-
then I like to add, sir, one more thing, that so many doctors, they have this femtosecond laser, but they're not using it. They're still using microkeratomes. I mean, I don't know, this is something out of the way, but there's so many doctors, they want to sell their femtosecond lasers, and they tell us that we've hardly used it because we have been using all the time microkeratomes.
No, I don't agree with that one. Most of us are using both the things. It depends on the patient and whatever the patient is willing.
Yeah.
Of course, femto has a consumables,
Yeah.
so it's more costly.
Yeah.
But otherwise, I think it's a fantastic machine.
Yeah.
It gives a very good and predictable results.
And what about the glare? I mean, because we are using too much laser with the femtosecond lasers. Is there any glare difference between the two?
No, there's no glare. Only thing the pain is little more. If you talk about the post-op pain,
Yeah.
maybe in microchrome patient may be comfortable within 2-3 hours.
Yeah, yeah.
But the femtolasic, it may be around 5 to 6 hours.
Otherwise,
That's all.
no difference in glare.
No difference in the glare results or any other things like that one.
So
Thank you.
glare has got much, and I think we should measure all the pupil sizes.
I think,
And we should, if possible, should be correcting our, because we measure pupil size in every patient and we increase the optical treatment zone. And if it is beyond that, beyond our increase, we always inform the patient that you already have night vision problems and that's gonna stay. So, you know, you don't complain later post-surgery.
and second, in the older machine, there was a decentered ablation sometime. That caused also the glare. But that's not common with the modern machines. So I think femto is a perfect thing, microkeratome is a perfect thing, smile is a perfect thing, and even the advanced surface ablation is a perfect thing. So all are working. That's why all are working.